What is granulomatous inflammation divided into non-caseating and caseating subtypes? What is non-caseating granulomas? Lack central necrosis. Common etiologies for non-caseating granulomas include reaction to foreign material, sarcoidosis, beryllium exposure, Crohn's disease, and cat scratch disease. Caseating granulomas exhibit central necrosis and are characteristic of tuberculosis and fungal infections. What is DiGeorge syndrome? Developmental failure of the third and fourth pharyngeal pouches. What is DiGeorge syndrome? Due to 22q11 microdeletion. What does DiGeorge syndrome presents with? T-cell deficiency, lack of thymus, hypocalcemia, lack of parathyroids, and abnormalities of heart, great vessels, and face. Severe combined immunodeficiency, defective cell-mediated and humoral immunity. What are the etiologies for SCID? Cytokine receptor defects, adenosine deaminase, ADA, deficiency, MHC class II deficiency. Cytokine receptor defects. Cytokine signaling is necessary for proliferation and maturation of B and T cells. Adenosine deaminase, ADA, deficiency. ADA is necessary to deaminate adenosine and deoxyadenosine for excretion as waste products. Buildup of adenosine and deoxyadenosine is toxic to lymphocytes. MHC class II deficiency. MHC class II is necessary for CD4+ helper T cell activation and cytokine production. SCID is characterized by susceptibility to fungal, viral, bacterial, and protozoal infections, including opportunistic infections and live vaccines. SCID treatment is sterile isolation, bubble baby, and stem cell transplantation. What is X-linked agammaglobulinemia? Complete lack of immunoglobulin due to disordered B-cell maturation. Naive B cells cannot mature to plasma cells. What is X-linked agammaglobulinemia due to? Mutated Bruton tyrosine kinase, X-linked. What is the caveat associated with X-linked agammaglobulinemia? Live vaccines, e.g., polio, must be avoided. What is common variable immunodeficiency? Low immunoglobulin due to B-cell or helper T-cell defects. CVID increases the risk of what? Increased risk for bacterial, enterovirus, and Giardia lamblia infections, usually in late childhood, increased risk for autoimmune disease and lymphoma. IgA deficiency. Low serum and mucosal IgA, most common immunoglobulin deficiency. IgA deficiency increases the risk for increased risk for mucosal infection, especially viral. However, most patients are asymptomatic. Hyper-IgM syndrome. Characterized by elevated IgM, due to mutated CD4OL, on helper T cells, or CD40 receptor, on B cells. What is the effect of the mutation leading to hyper-IgM? Second signal cannot be delivered to helper T cells during B cell activation, so cytokines necessary for immunoglobulin class switching are not produced. No class switching in hyper-IgM syndrome leads to what? Low IgA, Ig, and IgA result in recurrent pyogenic infections due to poor opsonization, especially at mucosal sites.
What is Wiscott Aldrich syndrome? Characterized by thrombocytopenia, eczema, and recurrent infections, defective humoral and cellular immunity.
What is Wiscott Aldrich syndrome due to? Mutation in the WASP gene, X-linked. What are the complement deficiencies? C5-C9 deficiencies, C inhibitor deficiency. C5-C9 deficiencies. Increased risk for Neisseria infection, in gonorrhea and N. meningitis.